Oh, thank you for recording that after I said all that.
Yeah.
I guess that means it's time to start. Welcome to our first new version of the Partnership Huddle. I'm Joy, as you can see with my 3 letters.
Hi, Joy.
Hi,
Joy. Hi, Joy.
Okay, so what I wanted to share today is prognosticograms. Maybe I will start with, I was hoping to have my results of the one that I have out right now, but it's not here, so we're gonna do kind of a mishmash. So let me start with, maybe we'll start with the beginning. Start at the very beginning. So there is a company. Did anybody read the little blurb that I sent last week? So there's a company, Atropos. Yes? Oh, yay. No. There's a company called Atropos Health. They were started by a Stanford doc who said there is so much rich data in our EMR. We need to be able to figure out how to be able to pull from it better and be able to get better analysis from all of the data that we have. And so they started this company called Atropos Health. And it is across the, I don't know, at least country. And so there's 2 different versions of EMR that you can use. We, as Stanford Medicine, we have a contract with Atropos Health. And so we are allowed to go and ask for any kind of random question about our data, about our Stanford healthcare data. And the way that you do that is you go to atroposhealth.com, you request a prognostigram to be able to help you understand what could be happening in the future, or like based on what has happened in the past. So I already signed in. Confirm and select question type. So we want to get a prognosis. What's the likelihood that something is going to happen? And then we write a question in here. You can choose whether you're going to use their PICO framework, but whether you do or whether you don't, it's all just writing. And then you can choose whether you need it now or if you can wait. You can download documents, and then you just press send. And it goes to a real live person, a real live doctor person, who then goes through and figures out what question it is that you're really trying to ask. They come back to you with some follow-up questions, and then they take what you wrote in your freehand text, in your non-clinical freehand text, and translate it into a way that the system can ask questions. So I did for one of our write projects, Hurley, the one in your group.
Are you sure, Joy?
I am sure this time, yes. The one in your group. It did take me a second to make sure, though, right? So this group, this is M4, so the medicine ICU has had an increase in number of lung transplant patients, and we get the most complicated of the most complicated, and like it's hard for them to wean off of trach. And when in going through our root cause analysis, one thing that we found is one of the big issues that's making it hard for these patients to get off trach is their anxiety. Your lungs aren't working, you can't breathe, and then you get this thing and then somebody's telling you that you need to make it even harder to breathe. And so then they get anxious. And so since this is the patient population that comes in that we see, the thought was, well, how much, like, is there something that could be done earlier? Is there some anxiety? Oh, we talked to the transplant team, and they support people who have already had a diagnosis of anxiety, but nobody else. And so the question is, well, is this a big, broad thing? Do most people have anxiety? Is there something that we can do earlier? Now thinking about it, the question we asked is probably not right, based on what I just said. But so what we did is I sent this in with our nurse lead, and so then Gavin, one of the informatics clinicians, said that he's covering for Will. Will is the provider who started this. And he says, thank you for this interesting question. Brings me back to my residency days covering MICU on M4. He says, unfortunately, we can't just do M4, as you asked. And then I wanted to double check some other things. And so I checked this in with my lead. We said, okay, yeah, you're right. M4 isn't going to do it. So let's do this by trached, no trached, for a short period of time and trached for a long period of time. These trached for a long periods of times are the ones that are definitely going to make it into M4. And then in terms of trying to figure out, did they have depression before versus after? Here's how we're going to check it out. So he says, great. So we're going to work on it and return it once it's completed and reviewed. I had hoped, this was on 2/6, so I had hoped that we would have it in by now, but my guess is it'll be coming in the next couple of days. And so I wanted to show you, here's one that was done. This one was for one of the VBC projects. We were working on musculoskeletal disease. And so we were trying to figure out what are different factors that we should be looking at to be able to help focus our work so that we were working on the most important MSK patients. And so the wording for this one, we have a whole bunch of docs. And so the wording was created. Here you can see that Will is the one that was going through all these different conversations with me to be able to figure out how do we want to make sure that this looks. And then at the end, not only do we have a whole bunch of documents, but he gives his qualitative version of it in my email. And so let's open some of these PDFs and see what kind of information we get. Oh, never mind, not that one. That's not my information. So this was the question. Is there an increase in the number of MSK-related encounters for patients with the following diagnosis compared to the general SHC population for fibromyalgia, depression, diabetes? And so he made several cases, one for diabetes, and then I think the next one was for depression. So their summary is, we identified patients with a history of office visits and prescriptions. There were 25,000 patients with a diagnosis of diabetes and outpatient visits. As a control group, there were 25,000 with no diagnosis of diabetes. And so they chose what sample size they were going to be using, but an ICD code other than diagnosis and an outpatient visit. And they say those with diabetes had a higher rate of healthcare utilization. They talk about E-values. So that paper was talking about what an E-value is. In conclusion, diabetes patients generally had higher rates of healthcare utilization for all reasons and for MSK-associated reasons. So then we see the demographics, the methodology that they ended up using, all the different codes that they used, the specific patients and their populations. Analysis with p-values. And you can see this is on page 8 of 32. So it keeps going and going. And the analysis is pretty amazing. Okay, that's what I wanted to share. What thoughts? Hurley looks,
I'm made of
yeah,
questions.
Hurl.
So I want to go back to the beginning on this. So
Yeah.
Atropos is not Epic.
Is not what?
It's not Epic. They're not Epic,
No, it is a
but
company started by a Stanford provider, a Stanford doc.
they're totally plugged in to REHR. They have access to everything that's in Epic, it sounds like.
They have everything. They have patient data. They have demographics. They do not have location, as I saw that they didn't have M4.
Okay.
I don't know that they have provider
And
specific information.
And they have a contract with Stanford to perform this service. And they're
So you can give yourself an account, use your Stanford email address, and you can do what I just did.
because you're not talking with an analyst. That was a freaking physician helping you do biostatistics
Mhm.
on these patients.
Well, I don't know what, like, who does what. My guess is he's like the salesperson, like the translator,
Yeah,
because there's so much that, like, I don't know CPT codes and all
Right.
those diagnosis codes. So
right,
he's figuring it out for me.
right. And he probably, it's amazing. Like they've gotten the research method so standardized that he knows what inputs he needs to get, or she, and passes that along to the analyst. And I'm sure that's crazy automated. Otherwise they just couldn't
Yeah, the rest of it must be crazy automated.
Yeah.
But this is so personalized. Like, you saw the number of emails that went through.
Yeah.
Well, I'm sorry, when you're done, Harold.
I go ahead. I'm gonna process more.
So first thing that jumps to my, is I would love to connect up a rep from this company with like Lisa Shea, Purnima, the heavy duty analyst, or the people who love to analyze data in our work group, just so they can see it and see if it might be a benefit. Because it looks like at this first pass, it looks really valuable. I just don't know, I think maybe where Hurley is like, well, we have Epic, and we have people pulling data from Epic, and then we have this other company who's pulling data from Epic, but they have this like really smart physician type person doing it for you. And I see value in that. So that's kind of where I'm trying to figure that out. So I definitely would like to have someone touch base with our kind of work team.
I'm trying to figure out where this fits in what we do, because if we can't figure out a way to say, hey, when you're doing this in your projects, you should be thinking Atropos. And I think it's primarily during diagnostic, right? It's primarily during, on the left side, when you're asking all the questions of current state. Basically they've created a solution to get concrete answers to basic research questions.
So Joy, so I'm still very much lost. I think it's an excellent tool, and especially with the kind of hand-holding and support you've gotten, it's fantastic. So I'm just, maybe I missed it, but based on what you were trying to solve for is really just, how do we figure out how we can wean the lung transplant patients that have anxiety? How do we ensure that we're able to wean them off trach support sooner so that we can reduce length of stay and discharge them? Was that your
Yeah,
question?
so our lead was thinking, oh my gosh, I can't believe how many patients are not diagnosed for anxiety. How many of us in general have anxiety, but don't either know it or are in a place where you don't feel it's okay to ask? And all of those patients are gonna make it into M4. How do we keep them from coming into M4 in the first place? How do we keep them from being anxious so that they can get weaned and get off vent so fast that they don't even make it into M4? Wouldn't that be amazing?
Yeah, but if they have a lung transplant, then they're going to come to M4, right? It's a question of
No. Only
They
20%
can-
of patients go to M4, and they're the worst case. What I found out recently is that most patients don't even get trached.
most lung transplant patients don't get trached.
No, they get a short term, I don't remember what it's called.
But they do have to go to
Two-
the ICU. I mean, they after the transplant, they're in the ICU for a few days before they
They're
can
in-
be discharged.
They're in J2.
Ah,
And from J2, most patients go to the floor.
So M4 is our
Don't
highest
do
level
well.
ICU.
The ones that don't do well go to M4. And then what happens is, then all they're waiting for is this trach and their anxiety. And they're sitting here for a year. Feels like a year. Some of them are.
And Joy, did I hear you say that the hypothesis, or at least the belief, is that there are patients with undiagnosed anxiety, and if we could have diagnosed the anxiety sooner / at all, we could give them care, we could give them resources that could help them get off the trach sooner, not decompensate and not end up on N4.
Right. And
Um,
maybe it's not even diagnose them earlier. Maybe it's just giving them all the tools to be able to deal with stress and how do you like relaxation techniques and whatnots beforehand. Give it to everybody. Maybe.
And remind me, what was the research question that you ended up asking them for the trach project?
I think I didn't read it to you because it wasn't listed, but I can, let's see.
God, I'm just thinking, like, this should be, everybody that goes through right should be made aware of this service.
yeah.
And then I'm wondering, if we open up the floodgates on Atropos, can they handle that? Is that what they want? Is their contract, like, is any part of their
I
contract?
know.
I was thinking about that too. It's like
Yeah, like
right now, is this under contract where they're like, okay, we piloted with you.
Yeah,
We'll give you like 6 months of free, and then, based on volume, we'll start
Yeah.
charging you per user,
right.
or worse, per
Right.
hour.
So
But
I
maybe-
think we did
Okay, the
something
question we
similar.
asked,
Go ahead, Joe.
sorry, the question we asked, we said, we're doing a quality project to reduce time for lung or heart-lung. Here, let me open it and you can see it.
I'm sorry, could you say it again, Joy?
I said, hold on, let me open it so you all can see it.
Oh. I thought I missed it, sorry.
Okay, there you go. You can just read it to yourself. That'll be faster. So this is what I originally submitted. So I was looking at the overall patient population.
So the question is, of those patients transferred to M4 during their
No.
stay?
Oh,
No.
yeah. So what we were trying to do was, of the total population versus M4. And so it turned out that my question wasn't very good. What we were trying to figure out is how common is anxiety for this patient population, for patient populations, for the heart-lung transplant.
All of them, or just the ones that go to M4?
When I first started, it was M4 versus other,
Okay.
but he couldn't do that. So
Because
when
he
we
can't get
changed
location
it,
data.
because they didn't get location data. So then when we changed it, let's see, is this my original? Nope, it's the wrong one. Okay, so when we changed it, it's now comparing no trach to trach for less than a month to trach for greater than a month.
And is that like a proxy for location? Because if they're trach for greater than a month, they're probably on M4.
Yeah.
Oh, it literally says, so let's use that as our proxy. All right, and then tell me what the question is again.
The question is, how big and broad is anxiety? Is anxiety just an issue that we deal with in M4? Or is it something that everybody deals with and just doesn't know it?
So putting it in statistical terms, so is the rate of anxiety higher for those patients who are trached for greater than a month, ergo M4 patients, than it is for everybody else?
Well, in the I would expect, yes, it would be higher, but is it high? Like, is it still high in the others? Is it something that makes sense to have does it make sense for us to do something in M4 around anxiety, or does it make sense to do something earlier for everybody?
And what answers to the question would tell you one or the other? Like let's say the answer is yes. Patients on M4, there is a relationship between the rate of anxiety and the duration of their trach.
Then it probably means that it's just something that M4 deals with and most others are smooth sailing. We have some patients that make it out with a lung transplant in 2 weeks. Make it out of the hospital in 2 weeks.
But if the answer, oh, sorry, Joy.
But with the patients we see in M4 are here for months and months and months.
So then it's like a causal question. Are they on M4? Do they get, let's see, do they get anxiety because of the
Because they're on
duration of
M4?
their trach
Some
and they're on M4? Or did they already have anxiety and that's why they got to M4?
Oh, the other thing also is that, if these are lung transplant patients, they are, they are certainly, obviously, they're in M4 because they're very critical, but they are also, we are also impacted by their outcomes. So we cannot, we cannot wean them off too early, where they go back and then they die, and then that impacts our rankings for SRTR, right? Because the 1-year survival metric is something that we're trying to meet as well. So I think some of that plays into this as well. But the bottom line is, they're anxious. I would think any transplant patient, anyone that's going into a heart, lung, multi-organ transplant is going to be very anxious because they're suffering. These guys cannot breathe. They have very severe COPD. They're unable to breathe and they need another lung. And so, so I think the anxiety starts way before, but, to your point, Joy, is that something that we even ask for or even treat?
And the answer is no. When we were talking, and that's why this question came up, but we were talking to the team that does the pre-transplant prep of patients, and they only deal with anxiety if it's already been diagnosed.
So the learning is, in terms of everything else that we ask, that the one of the other questions or some information to be gathered around anxiety is an important one. But but I'm also thinking, right, what would be the time frame for us to discern whether, the anxiety can be alleviated in time, right? Because if it was predictable, if we could predict when a patient is going to get a lung, I think we can sort of take some steps in the back and plan for how to alleviate anxiety, how quickly to intervene. For a lot of these patients, they may be admitted today, they may get a lung tomorrow, they may get a lung in 6 months. So we don't even know when they're going to get the lung. So there are a lot of unknowns, I think. To ask I mean, I'm not dismissing the fact that it's important to ask that question, because maybe, clearly we're not, the lung transplant team isn't asking the question. But I think a lot of the anxiety also comes from the fact that there is unpredictability through the entire process.
The entire process.
It almost makes you wonder if, Mo, you've been waiting to say something. Go ahead, Mo.
No, I think we used this service a while ago when I was supporting neurosurgery, and I believe the team is still very small and they're funded by the university, and I don't know if they can take a lot of requests. And I was wondering, Joey, how long did it take them to respond to your request?
Well, let's see. So we finalized our question. He sent his note on February 6th, and I haven't gotten it back yet. And then
Let's
the
blow
other
'em up.
one,
Yeah, I think there are like 3 or 4 people from what I remember last time when we met, and then they're
That's
all
what I was afraid of. It's like
That makes
4
sense.
individuals who are gonna.
because I mean, his response is Will is off, so I'm doing his job.
Yeah. And you ask them for help and they're just like, sure, yeah, we'll help you. We'll do this. Like,
Yeah, and so they do quality types of questions. I think I don't know that I showed you, but they also do like treatment. What treatment should I use for this patient? What if like I have a patient who is blank, who has all this criteria, and what has worked for other patients like them in the past? Please give me an answer now. And so
Joy,
I
this
put
is so
I
cool.
don't need it in the next 48 hours.
Right.
So they're probably focusing on those.
Joy, thanks so much for bringing this. Yeah, gosh, this really needs to come to a team meeting. I mean, we need to be at least aware of this service.
I had it.
Boy, I wonder who their customer.
for
I
a
wonder who
long
their
time.
customer really is.
I think their main customer, I think the purpose of it was for doctors to be able
Right.
to, for that treatment. I have a patient who blank. What should I do?
Oh, it's for patient care, you think? Because I was just thinking, all these young aspiring physicians that want to publish, need to publish, and don't have the influence to get the QSU to help them do this research statistics. This is basically biostatisticians as a service is what this is.
Mm-hmm.
Okay, I've got to go at least. Thank you for doing this, Joy. This is cool.
Yeah, so I think the next question it asks you what kind of question, or no, actually it was the question before. It asks, oh, he's gone. Anyway, I'll send him a screenshot.
Thank you, Joy.
Thank you, Joey. Appreciate it.
Thanks,
Bye.
Joe.
Bye.